Good afternoon, everyone, and welcome to this Global Fund supported webinar on sustaining national health management information systems. My name is Nina Justnes. I work at the HISP Center at the University of Oslo, and together with my colleagues today, I will lead this webinar. We have seen dramatic decreases in global health funding and official development assistance. And this have had a serious impact in low and middle income countries. And faced with shrinking budgets, governments are forced to prioritize and to balance the cost and benefits of sustaining digital systems against other urgent needs. So today we are lucky to have Ministries of Health from several countries in Africa and Asia presenting their experiences navigating the new funding landscape and share how they are prioritizing digital interventions and discuss the importance of sustaining country-owned health management information systems. Next slide, please. Yeah. So this is our agenda for today. We will begin by setting the stage for the webinar, talking about the funding context and HMIS sustainability challenges. Then we will have three country presentations from representatives from Ministries of Health in Zimbabwe, Ethiopia, and Maldives. We were also meant to have Tanzania present here, but due to the political situation in the country, they were not able to attend, unfortunately. So following this, we will quickly introduce you to some of our shared resources for HMIS and DHIS2 strengthening in countries before my colleague Mike will talk about the shared service fee to sustain the DHIS2 platform. And we will open up for questions at the very end. So please note down any questions you might have during the presentation or write them in the chat, and we will address them towards the end. And before I give the word to my colleague Rebecca, I would like to give the floor to Michelle Monroe. She is a senior specialist at Global Fund, and she will say a few introductory words. So, Michelle, the floor is yours. Next slide, Max, please.
Thank you very much, Nina, and good afternoon, everyone. So I'm really happy to welcome so many of you today to this webinar. The Global Fund is contributing to supporting this webinar today because it's a key topic for many countries that the Global Fund grants support. And this topic will be an important factor as countries begin to plan their next cycle of funding requests to the Global Fund next year, as well as all of their other budgets. So the Global Fund is one of the largest multilateral investors in health system strengthening, including digital health. We invest in the national digital data systems in over 100 lower middle income countries, and that's including the DHIS2-based national HMIS and many of these. So I'm hoping today's discussion will be a good opportunity to explore how governments and donors and other partners can best prioritize their investments and activities in the current landscape and to sustain digital data systems and their impact on health, and potentially even create funding or other efficiencies with these investments. So with that, I thank you very much for taking the time, and Nina, I'll hand back to you. Thanks.
Thank you, Michelle. I will then give the word to my colleague, Rebecca Potter. She's an HIS strategy advisor, and she will give us a bit of a background and set the stage for this webinar. So, Rebecca, the floor is yours.
Thank you, Nina, and thanks, Michelle, for a really great introduction, and of course, for the many years Global Fund support into these health system strengthening efforts in the countries. Next slide. So I think probably most people here are aware of the large footprint of DHIS2 functioning as this health management information system. And so this has been a system that's now in the majority of countries on this map, has been in place for many years, sometimes a decade or more, and containing all types of public health data that's being used routinely, week over week, month over month, to prioritize and allocate resources, ensure access to routine service delivery, and also increasingly covering more specific needs of certain vertical health programs and more individual level tracking, case-based surveillance, and other things that we have found in the wake of COVID-19, where systems have had to adapt to new public health threats. Next slide. Just to give you a sense of what's really in this integrated HMIS, these 75 countries, they are implementing in an integrated way. And so that core HMIS function generally starts with all of the routine data coming from service delivery sites like your facilities, really building up that foundation and reaching national scale. But at this point, most countries are at a point in their system maturity where not only are they covering routine program data coming from health facilities, but they've also incorporated routine surveillance, different types of case-based surveillance systems, electronic registries for things like immunization, and of course, individual level tracking for diseases of major concern like HIV, TB, and others. So at this point, the data that is coming through these integrated national DHIS2 systems very much serves as the backbone of the routine data for this health sector decision making. Next slide. So I think as Nina already summarized pretty well, it's a difficult time in development. There have been reductions in official development assistance for many reasons, from the restructuring of USAID funding programs, increasing funds being shifted towards security from European governments and other governments, and also just governments coming back from the COVID-19 pandemic. A lot of emergency funds were pushed out, and now things are catching up a bit. So this can, of course, have severe consequences in low and middle income countries. But there is another side to that, which is that sustainable planning and implementing many core foundational investments can actually reduce the risk of systems going offline or running at reduced capacity when you experience these types of shocks to the health system. So I think our last really big shock was the COVID-19 pandemic itself. And now this shock that we're seeing is a major shift in funding, the availability, and I think, as Michelle alluded to, the need to really use data to work smarter and make sure all of that our investments really count and that funding is getting where it's needed the most. It is a bit concerning that if over time these persistent funding gaps, they do ultimately lead to systems decaying. They're not being maintained. They're not able to meet current or adapting and new needs for the health system. And we've worked, we had WHO at a panel with us in Oslo at our annual conference. And I think one of the things that stuck with us is that these routine data systems are needed now more than ever in this landscape. So we're going to take a look at what some of the impacts have been with the reductions in ODA, but we're also going to look at many of the ways that countries are building resilient systems and some of the tools we have to share. Next slide. So with Gavi's support, we were asked to do a rapid risk analysis to understand the risk on these national DHIS2 HMIS systems, particularly during that very tumultuous time when a lot of the US government funding, there were stop work orders or overall cuts. And so we conducted this assessment across 48 low and middle income countries. These countries are supported by both Gavi and Global Fund, where DHIS2 is already being used as a national scale HMIS. And we looked at risk assessment categories such as the HMIS staff, institutional knowledge and capacity, hardware and infrastructure, and access to software, services, and data. We also compared this to their baseline system maturity, which was measured in the last DHIS2 maturity profile. And we had qualitative interviews with all of the different HIS groups that work very closely with the Ministries of Health to get a better understanding of what those specific risks were per country. So we do want to say that there are limitations of this assessment. It does show a snapshot in time of what things happened in May, but it could and should be updated because these are dynamic thresholds. This was also not a formal in-depth assessment that was validated by the Ministries of Health. It was conducted by the HIS network through the insights that we have. And of course, on any country level discussions, there would need to be further engagement, collaboration, and verification of what those real risks and challenges are in the countries. Next slide. So to give you a little bit of sense of what we found in those 6 months, quite tumultuous, you do see parts of the map going from green to yellow or from yellow to red and even dark red. So at sort of a summary level, we did see at least 17 countries were facing HMIS staffing reductions. 25 were facing a loss of hardware or infrastructure, some with a very immediate risk and some looking at a risk by the end of 2025 if intervention measures were not taken. And 36 were facing a loss of data access or somehow a part of that system collapsing. And a lot of that had to do with the core operations of getting data into that system and also making sure that things like server hosting, these arrangements were being done in a sustainable way. Next slide. But we did want to emphasize that this risk is highly variable across countries. So some countries went from medium or low risk to very high or high risk. But also some countries went the opposite direction. And so these kinds of risk scores, they are dynamic. It also requires routine monitoring from Ministries of Health to make sure they have their core building blocks in place. But this type of analysis also pointed us to some of the things that have, of course, increased the risk. So things like having perhaps a vast majority of financial support for the HMIS coming from a single donor. Very quickly, the loss of that funding pipeline can create a huge risk, whereas diversified funding that's split across many funders is providing a bit more of a resilient base. Another key thing we found was around staffing and being able to have core Ministry of Health HMIS positions as permanent staff. Countries that were relying heavily on secondments, when that funding disappeared, core functions also disappeared. So that was something to pay attention to. And I'll go ahead to the next slide, which I think shares a few of these summaries. So flipping the gears, not just around what creates risk, but also what creates resilience. We found that overall in these countries where DHIS2 is implemented as an integrated HMIS, it was much more resilient compared to many other vertical systems in the country. So we have heard, unfortunately, of some countries where logistics supply chain systems that were funded by one vertical program almost entirely collapsed overnight. We also know that some of these vertical programs, EMRs that were mostly funded from HIV or PEPFAR, also had a tendency to fall apart very quickly, and they had to sort of hinge back, sort of fall back on the HMIS as a primary source. So on the one hand, it is more resilient, this integrated approach. But on the other hand, as some of these parallel systems might collapse due to loss of vertical funding programs, it also creates increased pressure on the HMIS for delivering data in a timely manner. So I mentioned about core teams and the importance of having these core positions permanently staffed, diverse sources of financial support, so drawing across different donors and also ideally through domestic sources and budgets to make sure that that can be a sustainable source of funding over time. And also having sustainable server hosting and admin arrangements. So this isn't really speaking to whether those are in-house or whether they are outsourced, but rather about having a consistently funded mechanism that if there's outsourcing happening, the procurement can be taken care of, that bills can still be paid on time, that there's a place to do that, or if it is in-house, that there is the right in-house capacity to do a lot of these functions, which are beyond just their server hosting service, beyond just the server itself. I think the last thing we had to say here was also around the routine HMIS reporting that comes from facilities. In some countries, in some districts and geographies, it's heavily reliant on a vertical program resource for all of that reporting to happen. So looking at ways to diversify those routine reports that are really essential from an integrated program lens is critical. Next slide. So as we look ahead, we wanted to frame some of this messaging within regional and global agendas. So the Lusaka agenda that I think was pronounced as a document last year is really putting this focus on integrated delivery of primary healthcare services. Integrated HMIS really serves as the data backbone to that. So we're very grateful to many partners like Global Fund and Gavi over many years who have actually supported the integrated health health information system as a backbone for HIV, TB, malaria immunization within that context. It also calls for sustainable domestic financing and coordination and coherence. So reducing duplication, reducing fragmentation, and I think information systems are one of the ways we do that. Also, just last week, a new report from Open Data Watch. It was funded, I believe, by Wellcome Trust, but it came out and really calls for these long-term investments in country-led health information systems. And also some of our own insights from the HIS perspective and the HIS model have been featured in various blogs, including the Global Partnership for Sustainable Development Data, where we're really trying to continue to advocate for locally owned routine information systems, and also sustaining the digital public goods that they're built on. So local capacity, digital public goods, and the security of routine information systems for the long term. So with that, I am happy to hand back to Nina and looking forward to our country presenters. Thank you very much.
Thank you very much, Rebecca, for that elaborate background and introduction. I think on that note, I would like to give the word to our first presenter, Mr. Manas Moniani. He's the Deputy Director of Health Information and Surveillance Systems, Ministry of Health and Childcare in Zimbabwe. Please go ahead. Thank you.
Thank you very much, Nina, and greetings to all who are connected today. So I'm just going to make my presentation. So Zimbabwe, just like any other country, based on the previous speakers, has been affected by the funding freeze, probably not only from PEPFAR, but also cutting across other funding mechanisms. So I'll just try to go through our status. Next slide, please. Thank you. So yeah, we've seen that our major funders, PEPFAR, Global Fund, and HRIF, have reduced our funding in some areas, and with some aspects of service delivery, having the funds stopped or withdrawn. So when you look at this, you'd find that at some point, the government of Zimbabwe had to step in and cover some of the gaps, particularly, the ARVs, amongst other key medicines and laboratory consumables. And also in other aspects, the government has also come in to cover some of the gaps within the data systems, amongst other things. Also, just to mention that, the impact has not really been on the side of commodities, but also when you look at capacity building, this has been an ongoing process, and a lot of support was coming from outside. When you look at the human resources as well, as we speak, after, October, we have had a number of people being laid off because of the lack of funds. So if you look at service delivery, you then realize that when it comes to prevention services, particularly for the HIV programming, most of that area has been affected. If you look at issues around community mobilization, amongst others. Next slide, please. Yes, so maybe looking into the digital health core systems, essentially we have 4 core systems, the DHIS2, our Impilo electronic health record, the laboratory information management systems, as well as the logistics management information system. So when you look at our DHIS2, the core work continues. I think you also see maybe in some of the slides to follow that our reporting coverage hovers around 95% across the different programs. So we are doing well despite some of the funding gaps that have emerged. This is probably due to the fact that we have managed to make the best out of the time when we had some bit of funds attending the DHIS2 academies, and we are able to resolve minor issues around the DHIS2 configuration of new forms, creation of tracker modules, events, and the likes. But definitely, we will not be able to do without external support in as far as major upgrades and other things, technical issues are concerned. Then moving on to the electronic health record, the funding has been reduced. Development of the application or the system is also scaled down. This is where we have quite a number of HR also having been laid off. We were targeting that maybe we would have managed to roll out the solution, the system across the country. But because of that, maybe we will not be able to reach to all the 100% of our sites, currently hovering around 65% coverage of our institutions. Of course, there will always be some funds that will come from the government, but definitely it will not be enough to move with the speed that we had before, and also the thrust that we want to move with. And of course, the HR component, again, being a big gap there. Looking at our laboratory systems, the laboratory system has benefited from the C19 RM grant from a global fund, and of course with other funders, PEPFAR and the likes. And we're happy that the C19 RM grant was not much affected by these changes. So we've been able to implement most of our activities around this. However, there are other components that have been affected, cutting across, the different funders and the activities that we intend to do. Moving on to the ELMIS, where we look at medicines and commodities, distribution and maintenance of the stocks within our health facilities. You'd find that this system has been vendor locked, obviously owing to the fact that we did not service our license due to unavailability of funding. So all the works around improving the solution to cater for vaccinations and other plans are actually on hold because we are not able to move with the solution. So what it basically means is that of all the effort that we put in place, it has been halted, and we can't then realize the value that then comes with this system. We're just hoping that further engagements with different funders will help us unlock some fund and continue to implement this system. Next slide, please. So as Zimbabwe, we are also very fortunate to have received some funding from a global fund through the Digital Health Impact Accelerator project, where we have a set of projects that we are implementing, and also happy to mention that these have not been affected, by the ongoing fund cuts, at least for now, where we have managed to work around the digital health blueprint, which I am sure should be finalized and out before the end of the year. And then we'll be able to implement some aspects of the blueprint next year and the years to follow. Then we have also managed to run a data analytics and use a project, also just trying to leverage the data that we are generating so that it can be of use to policymakers. So now we are at the stage we've done the assessment. We are now moving into the actual implementation of the project. Then, of course, benefiting from a data analytics and use as COPs, where we meet with other countries and other partners to discuss and be capacitated around data analytics. Then we also envisage implementing a health information exchange, then adaptation of smart guidelines, and of course, DHIS2 interoperability are some of the projects around this DHIA work stream. Next slide, please. So in terms of our key priorities, certainly we want to realize the implementation of the DHIA projects. We also want to finalize the smart guidelines work stream. Probably at this juncture, we may need to, already we have stopped the further development and rollout of the EHR. So the effort probably now would be towards maintenance and then ensuring that where the solution has been rolled out, it continues to function optimally. Then, of course, we have already started working around aspects of e-learning, where we try to reduce the cost of in-class trainings. Certainly, despite a shifting in terms of what needs to be done, again, the resource gap remain big, and we need to engage within government, within Zimbabwe, and also within international partners, so that we mobilize resources for some of the work streams to continue. Otherwise, without this funding, you'll find that all the effort that we have put in place, all the resources, the funds and the likes will actually go down the drain. And on the other side, will not be able to influence or rather advise in terms of policy issues, in terms of improved care to the citizenry of our country. And of course, some of the things that we're already thinking around, which are low-hanging fruits, is the issue of ICD 11 and adaptation, and of course, the rolling out of a community health information system, which we have been piloting in one of our districts, and they have received indications that maybe we can move on to yet another district, but obviously the objective being to cover the whole country. Next slide. Just some pointers there. This is our platform for most of our aggregate reports. And like I said earlier on, you'd find that the completeness rates are really high. Where we have challenges probably is the aspects of reports coming on time, mainly due to power and internet issues. Next slide. This is again another DHIS2 instance where we run our campaigns, just hints so that you can see some of the platforms that we're running next. We also have an instance where we have medical records of patients who get admitted in our hospitals. And this is just a summary of the data that is coming out of that particular instance in DHIS2. Probably the last slide. Last slide is just showing the community health management information instance, which we have which are piloting in one of the districts in the country, where we have identified remarkable, results, and looking forward to scale this out to another district and more districts, pending availability of funds. I think I'll stop here and thank you very much.
Thank you very much for the presentation, Mr. Munyani. The next presentation will be from Mr. Antasai Amare. He's a digital health project manager at the Ministry of Health in Ethiopia. The floor is yours.
Thank you so much, Nina. Greetings to everyone. Welcome. This is Antasai from Ministry of Health Ethiopia. I will present on the strategic prioritization and partnership for sustaining digital systems in Ethiopia, what we have been doing, what we have done since this has happened. Previously we have made many initiatives for such kind of days. So we managed to focus on global good open source systems as a policy, as a country policy, and some of that policy have paid off when this can happen. So most of our systems, currently we have more than 54 systems that are nationally being deployed. Most of the systems are open source or they're global good. The other issues that we have made is in respective of assuring the quality assurance for any system that is going to be implemented in any public health facility has made when Nina was presenting earlier, I think, to a medium risk country. So these tasks have shown us many results, and I will try to present the challenge that we face and how we are trying to overcome those challenges. Next slide, please. So to give you just a background of the current system that we have, these are some of the core systems that we have been implementing throughout the country. One of the biggest systems that we had is ECHIS. The ECHIS is a community health information system, management information system software that we are using for our health extension workers. Currently, there are 29 million individual records in that system. From that, there are 9,000 plus health posters that are connected or that are using ECHIS to record both clinical and demographic data across the country. Overall, in agrarian setup, 49% of the agrarian setup are using ECH as a health extension worker. So we managed to distribute more than 35,000 tablets throughout the country. That is for the health post and for the health center. And it's been one of the systems that have been affected with these funding cuts, especially in the development and other areas, but with the support of Global Fund and others, we managed to keep it as a country-owned biggest system that we have. The other one is the AMR system. Currently, around 172 hospitals and health centers are using AMR systems in the country. From that, 44 facilities, more than 44 public health facilities are fully paperless and been working on that. I will come later on DHIS. The other global good tool that we're using is the human resource information system. Currently, more than 395,000 health workforce have been registered. This system manages health workforce from education to retirement. So when an individual join any medical school, the system will track uh, that individual, and we will have the number of graduates, students that are expected to graduate this year, the number of health workforce to be graduating and assigned to the ministry. Plus, once they graduated, we will track from hiring to retirement all the human resource activity within that uh, within that human resource information system. And the fourth system that we are currently been deploying is a master facility register. More than 51,000 health facilities, both their signature and service domain has been registered, and it's acting as a source of truth for all the facility information system for all our systems. We are also using IRIs. This is a regulatory information system. More than 21,000 users have been using this system. This is to get license to import a medicine and for including the distribution. We are using this system. The other supply chain management information that we have is named DAGO. DAGO is a messaging in the local language. Currently, it's been implemented in more than 1,300 facility. This made the stock management very easy at facility level. That can be tracked centrally also. With this, we managed to decrease wastage rates in more than 10%. Recent studies have shown that. The other big system that we have is the Smart Care EMR. This is to track all our HIV positive patients across the country. Any facility whose currently on ART is more than 50 will use this system, so that currently we have around 1,000 facilities who are providing ART service. From that, 926 facilities are using our smart care system, and that is connected them to the DHIS2. And this is also one of the biggest system. For vaccine and BedNet, we're using Embrana. And the last one is the digital payment that we are integrating into all of our regions. So these are some of our core systems that we are working on, but DHIS is the main system. Next slide, please. That the ministry is being using that system. So since 2017, we have been implementing DHIS as a national HMIS system in the country. With that, we managed to use our own calendar. As you know, Ethiopia has a unique calendar from the rest of the world that we believe is very unique and true. And we have also a separate budgeting calendar that we're using. So we managed to customize with the support of his Ethiopia and his team that to fit our needs and implementation. So we are using DHS to collect, validate, analyze, and visualize this HMIS information across the country. From the 50,000 health facilities in the country, almost 38,000 facilities are using the DHIS2 to report their HMIS reports through this system. Around 60% of these facilities are online, where 40% are offline facilities. We're not just using the DHIS as a national HMIS system, but we're also managed to customize the HIS tracker for TB to track TB, to track EPA campaigns, Just recently, we managed to use the HIS2 tracker to provide measles vaccination for more than 18 million children across the country. We are using it for NTD. We have used it for COVID tracker. In that system, we have more than 70 million individual record from from outside to laboratory information system. We have doing that. Also, we are using the HIS as an embedded system. For example, we have embedded weather transformation into the main HIS instance. We are using the HIS as a multi-sectoral system for units to track nutrition across different sectors, not only health, but agriculture, Ministry of Water and Energy, and others are using this DHIS platform as an integrated system. We're using it for planning, rehabilitation, and other systems. So in Ethiopia, DHIS is, I can say, is many things. Next slide, please. So just to give you some stats on how we are using DHIS, this is just the main DHIS, the main instance, HMIS instance. Currently, there are more than 9,000 dashboards that have been designed and been used across health facilities. With that, more than 35 visualization charts and maps have been drawn and put into the dashboard. 711 maps are there in data volume. I can say almost a billion record is there. Since 2017, there are more than 800 million records are there, more than 140 organizational units, more than 40,000 organizational units. These organizational units are both private and public. So not only the public are using the HIS for reporting, but also the private. There are many parents, user groups, users. If we can see, currently today we have 63,000 users that are using the national DHIS system. So this is a huge volume. Just in the last hour, I was just changing these numbers. More than 1,000 users have been accessing DHIS and using DHIS for their daily activity. So it's not just a reporting tool, it's the biggest analytic tool, I think, in the country. Plus, we are using the tracker to do individual level data reporting through DHIS. So we're using DHIS in many ways. Next slide, please. So we're not just using DHIS for this stat, but we managed to integrate the DHIS into some of our major systems. As I mentioned earlier, MFR is our master facility register. We managed to integrate that master facility registry to our DHIS system so that DHIS is not holding any facility recording or facility information. We managed to build a unique mediator between the MFR system and the DHIS so that anything that happened in the MFR will automatically be happening here. So the master facility registry is managed and owned by our regulatory department. So if a facility is closed today, it will also close in DHIS. If a facility have been upgraded, it will get that data immediately. The other interoperability that we have in final stages is integrating DHIS with our ECHI system. In that ECHI system, one of the biggest systems in the country, so that any report that is generated or captured in ECHS can easily be integrated into DHIS. We are piloting that one across multiple worlds, and we are getting very successful. So we're using DHIS to integrate to other systems also. Please, next slide. There are also many integrations to AMR and other systems. So what have we prioritized when these fundings come? The first thing is focusing all our investment on mission critical systems. These systems are the one that I showed you earlier, the AMR, DHIS2, MFR, HRS, and ECHS. We managed to refocus all the government funding or the money that we are getting from Treasury into the core systems and making sure these systems sustain and not corrupted. And the second thing that we managed to do is there are some duplicative effects. There are some duplicate of systems across the country. So we managed to consolidate those fragmented systems into somehow repeated systems. And the other thing is we maintain continuity of the national backbone as the ministry from the get-go is heavily investing in the connectivity, health net connectivity, hosting platforms and others. So we managed to maintain that as is originally been funded by the ministry. We managed to continue with that and ensure essential service continuity at facility level. There are some facility systems that are rely on our support or this implementing partner support. So we managed to support those facilities of these essential systems, and we have some good results that we have achieved. Next slide, please. So what have we faced through these cuts? The first thing, there are many partners that have been implementing different systems across the country. That's made many fragmented system or the knowledge base of understanding us. We have a very limited human resource at the ministry. There is a very limited knowledge base. So as systems are fragmented and being implemented by different partners, we faced with many fragmented systems, and the knowledge base for each system and getting that knowledge base and making continue was one of the challenges. Some of the partner were supporting us in governance, interoperability, and other things. Some of them have continued with the support of Global Fund and other partners, but especially those funded by USAID and others have not progressed. So this caused limited financing. The HR capacity at the ministry was a bit issue. The computers that we are using at the facility level, especially for the HIS, have aged for more than 8 years. So changing that was a bit issue. And many partners were working on data quality and use, and getting funding for that data quality and use is a big challenge still now. So as the data volume been increased, as we are reaching 1 million records in the country, managing that, enhancing the performance of the system is a bit of a bottleneck. So we are working on that also. Next slide.
Sorry, Mr. Amar, this is your 2 minutes warning.
Thank you.
Perfect, thank you.
When we're saying consolidated systems, we managed to build the infrastructure to hold this consolidated system. So currently we are building 7 data hubs across the country. We're connecting those data hubs through our SD-WAN connectivity. Next slide, please. So that we will have the infrastructure to build a unified digital health system. With the support of Global Field, we're building a huge ETO AMR that is a multi-tenant AMR that connects to the national ID, that supports health data, telehealth that can be hosted in our data warehouse and can give us analytics that can be integrated to digital payment and AI and machine learning, that also being integrated to the supply chain. and can have a client app. This is a unified system that we are currently building on with the support of Global Fund and to have this integrated system. Next slide, please. So in the governance area, we're also working on an enterprise architecture to manage all this fragmentation in this system duplication. So we're working on the governance area. We're also restructuring our human resource from the ministry to the lower level to handle the gaps that has happened by these cuts. Next slide, please. So this is a final slide in a way forward. I think realigning donors and government priority is the first thing that we're currently working. So under a unified digital health investment framework, we want to realign what we can find from donors and any support that we are getting. The other thing is implementing this national information exchange and shared health record as a multi-tenant system by engaging private sector is also the next thing that we are working on, that by inviting these private companies and working with donors, we can accelerate the implementation of this national system so that we can easily mobilize domestic funding to reduce resilience and external financing issues. Thank you very much. I will be happy to answer the question later on. Thank you.
Thank you very much for the presentation, Mr. Omar. Our final country presentation today will be from the Maldives. Ms. Mariam Asna Said will present. She will talk about the HMIS Sustainability Roadmap for the Maldives, and she is the HMIS Implementation Lead for the Health Information Management and Research Division of the Ministry of Health in Maldives. So the floor is yours. Thank you. Mariam, I think you're muted, perhaps. I think you're unmuted now, Mariam. Can you?
Yeah, thanks. Can everyone hear?
Yes, we can hear you now. Thank you.
Hi, good evening from the Maldives. Today I'll be sharing the HMIS Sustainability Roadmap for the Maldives, a strategic plan developed to ensure that our national health information system remain reliable, integrated, and future-ready. This roadmap reflects our lessons learned, our priorities, and the partnership that continue to shape our digital health journey. Next slide, please. Currently, the Maldives HMIS include both aggregated and individual data systems that feed into our point of service application. These systems are at different levels of maturity. Some are well established, while others are still evolving. However, one key challenge remains that the integration and the coordination between these systems. We often see fragmented data flows, limited interoperability, and the duplication of reporting efforts. Strengthening our HMIS sustainability is therefore essential to ensure that data from all points of care, from islands to central level, is reliable, timely, and supports better health decisions. Next slide, please. HMIS sustainability is not just about technology, it is about ensuring that our digital system continue to serve the health sector in the long term. Without sustainability, we risk losing data, knowledge, and human capacity each time project ends or staff change. A sustainable HMS ensures that data continuity, support evidence-based planning, and reduces dependency on external technical assistance. Next slide, please. To achieve sustainability, we have identified a few key pillars. First, governance and coordination, ensuring clear leadership and accountability. Second, capacity building and institutional knowledge, so skills are embedded within the ministry. Third, financial and technical sustainability with long-term resource planning. And finally, partnerships and collaboration, because no single actor can sustain the system alone. These pillars guide all our strategies in the roadmap. Next slide, please. One of our top strategies that is multi-partner alignment and coordination. We are working to convene our development partners, WHO, UNFPA, IOM, UNICEF, and the World Bank to jointly plan and budget HMIS activities. This helps reduce duplication and ensure harmonized investments. The second strategy focuses on capacity building. Through UIO and NORAD, we aim to continue mentorship and advanced teachers to training both remotely and through periodic on-site visits. Importantly, we are shifting from individual training to institutional capacity, ensuring that expertise remains within the ministry even as people move on. Next slide, please. Our next strategy focuses on strengthening partnership with the HISP network, particularly HISP Sri Lanka, India, and Pakistan, and any other countries ready to share knowledge and experience. This collaboration are crucial for ongoing technical support, system upgrades, and metadata design. We also plan to leverage regional and global mechanisms such as WHO CRO's digital health support and UNFPA's regional initiatives on Ramnaka and SRH indicators. Peer learning with neighbor countries like Sri Lanka, Nepal, and Bangladesh will also help us adopt best practices and stay current with reaches to advancements. Next slide, please. Knowledge exchange and visibility are equally important for sustaining momentum. We plan to actively participate in the DHS2 annual conference in Oslo and his Asia conference and community of practice. This platform allows us to showcase the Modi's digital health journey, attract collaboration, and access new funding opportunities. We also encourage the ministry staff to share their work through abstracts, posters, and demo apps, strengthening professional networks and institutional recognition. Next slide, please. In the next 12 to 24 months, our focus will be on consolidating partnerships, institutionalizing technical skills within MOH, and establishing clear governance and financial mechanisms to sustain the HMIS. We also review our national policies and align them with the Modi's digital health blueprint, ensuring that HMIS remain a core component of the national digital health architecture. The roadmap surveys both a guide and a commitment to build a data-driven health system that supports better outcomes for every Maldivian. Next slide, please. To conclude, sustainability is not a one-time goal. We believe that it is an ongoing process for strengthening, adapting, and learning. By aligning our partners, investing in local capacity, and institutionalizing knowledge, we can ensure that the Modi's HMS continues to grow strong each year. Thank you.
Thank you very much for the presentation. Thank you to all presenters for enlightening talks. It's very interesting to hear how different countries have faced their reductions in official development assistance and what they're doing to meet these challenges and sustain their HMIS. So we're going to shift gear here a bit. I just wanted to give you a background on DHIS2 software. As you know, many of you probably know, it's used as a national HMIS in 75 countries, amongst them the three who have presented here today. And the development of this software is a global collaboration managed by the HISP Center at the University of Oslo. And the HISP Center is also part of the global HISP network that comprise of 24 local HISP groups that provide direct support to government partners and local implementers of DHIS2. Next slide, please. So in addition to managing the DHIS2 software development, the HISP Center also develops shared global resources to support DHIS2 implementations and information system strengthening. And we would like to share a curated selection of these resources with you today. namely the DHIS2 Maturity Profile Assessment, the DHIS2 Implementation Planning and Budget Guide, as well as the Core Team Capacity Building Framework and Tools. Next slide, please. Yeah. Thank you. So the DHIS2 Maturity Profile Assessment is a tool that can be used to assess the maturity of DHIS2 in a given country. It encourages investments in core DHIS2 capacity. In other words, in foundational areas like leadership and governance, security and infrastructure, things that people are usually not that interested in investing in, but it's very important to invest in to keep DHIS2 implementations afloat. And this contributes to sustainable HIS, supporting health programs, and assist also in planning DHIS2 implementations and strengthening activities. And the tool is intended to sort of highlight gaps and recommended activities to meet these gaps in country, which can feed into a plan for the DHIS2 implementation, and ideally also sort of aligning investments in donor interventions. Yeah, next slide, please. So proper planning and budgeting is an important activity in order to sustain a good system design over time, making sure the DHIS2 system develops in a healthy way, that it's updated frequently, responds to user needs, and operates according to rules and regulations. So for this, we have the DHIS2 budget guide that can assist countries with planning and budgeting in new interventions and programs on existing DHIS2 implementations. When countries are starting up with DHIS2, both sort of pilots and scaling nationally, as well as budgeting annual maintenance costs. Next slide, please. Yeah. So the final resource I would like to present is our core team capacity building framework and tools. The DHIS2 core team framework helps to develop long-term sustainable capacity building, whilst the core team toolkit consists of resources to assist in assessing internal skill, identifying human resource gaps, planning and budgeting future capacity building activities, and defining and creating interventions to build future capacity. Yeah. Next slide. I think now that we have talked about the tools and frameworks for how to strengthen HMIS and DHIS2 in countries, we would also like to share with you a bit how we're working to sustain the DHIS2 platform developments. So before we open up for questions, I would like to give the word to my colleague Mike Frost here. He is part of our business development team at the HISP Center. The floor is yours, Mike. You're muted. Sure.
Hey, can you hear me now?
Yes, we can hear you now.
Apologies, my screen disappeared right as you were coming to me, and I cannot seem to locate it. So, going off of memory, what we're talking about now is we've seen a lot of examples of the impact of DHIS2 in some of these countries. There are quite a few more that rely on DHIS2 as a critical part of their digital public infrastructure. And the same kind of financial and economic pressures that have been hitting countries individually are also affecting the core team and the activities that are behind maintaining and sustaining DHIS2 as a digital public good. This is something that we've actually had on our mind for a couple of years and have been working closely with some of the key global donors behind DHIS2 that also support many of your countries to look at different financial mechanisms that we could use to ensure the sustainability of DHIS2 long term and make sure that it remains a digital public good that's open source with the mission specifically to enable local ownership, digital sovereignty for low and middle income countries with their national systems. So I've thrown up here a couple of the statistics that we have on hand about the use. But the reason for sharing this is to show kind of the dramatic impact that these types of national information systems are having on the world, and that have been enabled by kind of the core funding that has come through many of the global health initiatives, the donor organizations. And we've had the task of looking at mechanisms that will enable this to continue going forward and have been given some directives by the donor organizations that support us. So if we take a look at the next slide. So what we are working on now, hang on just 1 minute, switch my own slide. Okay. Yes, we have seen there's a huge shift amongst the global health initiatives to focus on country funding, to have less funding that would go to the University of Oslo, for example, to maintain DHIS2 as a product, but not because they think that DHIS2 will be used less or that countries are moving on, but more that they want the country funding and the country priorities to be aligned with the maintenance of DHIS2, which is strongly in keeping with our own perspective. We always have considered that the host governments are the main clients for DHIS2, that the functionality of the software should reflect the priorities of the governments who are closest to the people that they're serving, the vulnerable populations, the public health challenges. And we've been, again, working with several donors to think this through, and not just with regards to DHIS2, but actually the whole digital public good ecosystem, many of which have relied on the same kind of direct donor funding to keep the lights on, to be able to maintain security patches, to work on interoperability, to produce regular releases and upgrades to the software. This is also coming linked to the Lusaka agenda, which really wants to ensure that there are solutions for health that are fit for purpose for LMICs, but that they are sustainable and that they're able to continue going forward, with an emphasis on helping countries to be able to sustain a lot of their own systems, so that when we face a crisis such as we've seen this year, where many of the externally funded information systems have collapsed, that we're seeing a lot more sustainability and resilience from systems like DHIS2, where the emphasis is on having local ownership and local teams that have the technical capacity to support them. So what we are looking to introduce in the coming year, and again, you will get a lot more information about this in more detail as we work the things through, both with you as the country stewards and also with the global organizations behind it, is to introduce what we're calling a shared service fee. So we see this as a collective action approach to sustaining a digital public good, where there's an annual fee per production instance of DHIS2, and the fee that is established is based on the economic status of the country as defined by the World Bank economic classifications. The funding for this is meant to be orders of magnitude lower than would be paid for private or proprietary software. It also is not meant to be some kind of vendor lock-in, because there are many different vendors that can support DHIS2 systems. We, the University of Oslo, don't do the implementation. Rather, we have a very large community that does. And so the idea is to include this as a line item budget piece within the proposed grants and national budgets, to be able to support the main team and activities that are sustaining DHIS2 long term, which includes the updates, the testing, the security, patches, bug fixes, documentation, all of the aspects that make DHIS2 a digital public good and a relevant one continuing forward as technology changes and as improvements are needed. We've often been asked in this discussion, how are we going to enforce a shared service fee? And the simple answer is that we're not enforcing it in like a license. We will not be tracking down those that are not paying it. There are so many thousands and hundreds of thousands of DHS2 implementations. We actually don't expect to cover everybody and everything with this. But what we are doing is seeking institutional level agreements, both with the global health initiatives that are funding a lot of this work, and also with the implementing organizations that are supporting countries and with the host governments. The idea is to be able to maintain a list of those production instances nationally. The cost for the shared service fee is not based on the number of health clinics. It's not based on the number of users. It's nothing meant to be very onerous. It's meant to be something that is straightforward based on the production instance. And so that it's something that we are tying a fee which previously was paid by the donors. This is not new money. This is money that has always been covered by the donors to maintain DHS2 as a digital public good. We're now cutting that into very small pieces to assign to the national production instances throughout the world. We'll also have some tiered pricing for those private sector users of DHS2, as well as the high income settings that have started to adopt DHS2, with the idea that they would be paying much more, and that is able to subsidize the cost of DHS2 for low and middle income countries. We're not trying to make this a very complicated system. It's actually a very simple generic framework that can work with most procurement mechanisms. So that it's seen just as another one of the costs of using the information system. And we'll be working with the global health initiatives to make sure there's detailed budget guidance that comes along with things like country grants, country loans that demonstrate that this is an acceptable line item to be included in the projects that you have going forward. As I said, we're giving you kind of a quick snapshot and overview of this because we do want feedback. We want to make sure that the model that we end up putting in place is something that aligns well with your own mechanisms in country. For us, this is demonstrating kind of a collective action approach where we're keeping countries front and center for the priorities of the platform and ensuring that there's access to DHS2 as a digital public good long term, that it comes with upgrades and security excellence that is going to enable this to be a part of the digital public infrastructure for your countries for many years to come. More information will come out about this. There'll be a lot more information that we're sharing with the implementing organizations and the HISP network behind DHS2. And we just wanted to start getting the word out there that this is the expectation to maintain DHS2 and very probably many of the other digital public goods that you are relying on in your countries. I think I will stop there.
Thank you, Mike. And I think just before we move into the questions, we have a comment in the chat that says, so you're moving away from open source. Do you want to briefly touch on that, Mike?
Yes, we are definitely not moving away from open source. So DHS2 remains under the BSD3 clause license, which is maybe the most permissive open source license. Nobody needs to contact us to download or set up or use DHS2. What this is again at an institutional level with both organizations, governments, companies that see DHS2 as an integral part of the way that they operate, that they would choose to be a part of the shared service fee schema, which would be much, much less than paying for proprietary or licensed software, and also will prevent vendor lock-in because you can work with any vendor. It's an open source solution. So not changing the open source aspect of it, and also not intending to change the kind of activities of the HISP Center to be tracking down every potential use of this. But we do hope that the governments that are relying on DHS2, that are receiving funding from global health initiatives, will see this as a routine cost of maintaining their own national infrastructure. And it's something that can work its way into national budgets going forward. We will be releasing more information about the actual pricing and what this is, but I think everybody will be very pleased with the very low amount that we're talking about here. As we don't run like a business, we're run out of the University of Oslo. We don't have a board that we're trying to maximize profits for. We're not trying to get everybody in the world to have an expensive payment. Rather, we're just trying to keep this as a digital public good, keep it as open source, keep it available, and focused on the mission of supporting low and middle income countries.
Okay. Great. Thank you, Mike. And thank you all for your presentations. We're very glad to see that the countries are working to meet the decreases in global health funding and official development assistance with innovative solutions to sustain their HMIS. I think we will open the floor for questions. Please raise your hand if you have any questions or write them in the chat. I think we have a few questions there already. The first question I saw was to Ethiopia. It's great to hear the status of HMIS. What efforts are regions making to overcome heavy donor dependency for system support and insufficient domestic financing for sustainability?
Sorry, can you repeat one? I'm sorry.
Sure. It's great to hear the status of HMIS. What efforts are regions making to overcome heavy donor dependency for system support and insufficient domestic financing for sustainability?
So the country context, I think, is a bit different from other countries. Mostly for systems that are unified and that can be deployed from the center, all the support and the technical support is provided from the center, from the ministry. In the previous times, we managed to train and build a national support team that has included the regional technical working group also. We have managed to train them. So the system, the national HMI system is deployed at the ministry level, at the center. So the higher level technical support is managed here, but training, implementation, data quality, and others, we are trying to prioritize some of the applications, some of the priority areas, and implemented across the regions. But most of the technical support and the management is done from the ministry side. Thank you.
Thank you very much. We have another question here. How can DHIS2 be better aligned with other national digital health platforms to support interoperability and reduce data fragmentation? I guess this is a question to everyone.
I can share at least some thoughts about that. We have been taking very seriously for the last 3 years or so, having a more direct approach towards engaging platform to platform with other technologies that the countries we are in rely on. And we've really stepped that up this year. So we have some intensive working groups going on with some of the other DPGs, but also some of the other large-scale software that are used widely. For example, the Esri that has ArcGIS that many countries rely on. So the intention from our side is to be able to produce more reference architecture for you all to have solved some of the bigger challenges of connecting platform to platform generically, so that in the country, then the adaptations, the work that's required will be less. We see this also as a key part of the sustainability of these technologies going forward, making sure that with a reduced investment, these systems can be connected to one another. They can work for the countries with a wide variety of configurations, and that they can pull together a lot of the services that are necessary in the public sector. So that's at least from the HISP Center, that's a bit of how we're trying to approach this.
Great. Thank you, Mike. We have a question here as well. Will the DHIS2 implementation planning and budgeting tool be part of the Global Fund GC8 funding application? We had Michelle Monroe answering in the chat from Global Fund. I'll just read her response there, but feel free to fill in any additional information, Michelle, if you have anything there. But it is not a required tool for the funding application, but we do suggest that it would be very helpful for countries to utilize it, as well as updating the DHIS2 maturity profile for the country for prioritizing investments for the funding requests. I wrote in the chat as well that we will share the slides, including links after this webinar is finished, so you will have access to both the budget tool and the maturity profile later today. Yeah. Then I think another question that maybe you can answer, Mike. Why is DHIS2 donor funded instead of country funded when there is a funding gap?
Of course. So I think, quite honestly, we are all very concerned, of course, about this funding gap this year, because this is a significant disruption to the way things have operated for a few decades. I will suggest that there's another way to look at this from at least the digital public goods perspective, which is that many of the digital public goods were first invested into as innovations, as new and unproven technologies. And at this point, quite a few of them have grown up and matured to being really substantial fit for purpose platforms. And so it made a lot of sense that to encourage the innovation, donors were investing directly into the creation of these technologies. But we have probably passed out of the moment of letting 1,000 flowers bloom and rather need to spend some time now investing in the stable and ongoing use of these technologies in, real settings. So there has been the donor funding, which has enabled a lot of this growth. There will continue to be donor funding that supports many of the DPGs, but it is a transitional time also to recognize that many of these technologies have become just part of the infrastructure of the countries where they're being used, and should be seen as something that are a part of the national budget and the routine financial support from the countries that are using them.
Thank you, Mike. Then we have another question for our Ethiopia representative. For data fragmentation challenge, do you implement Open HIS, which is powerful for systems interoperability? And for digital payment, do you plan or implement GovStack framework?
Thank you for the question. For data fragmentation, we are currently implementing OpenHIM as a platform for the country for multiple systems. The system that I show you that has already been done. For example, the HIS with our master facility registry, and the HIS with our community-based community health management information system. We're using OpenHIM as a platform, but we are also experimenting with OpenFN recently. And for digital payment, currently we're using payment gateways system. So it's an open. We have opened our digital systems to the payment gateway. So we have more than 3 digital payment gateways in the country. So we're using the local gateways to integrate to multiple banks from our digital systems. Thank you.
Thank you very much. Yes, Mike, did you want to say something?
Sure. Just to say that I'm not familiar with the OpenHIS that you referenced, but if we're talking about OpenHIE or a specific architectural framework, again, there is a lot more that we are doing this year to develop out more comprehensive recommended reference architectures, working with various technologies. You mentioned GovStack. We are recently a new member of GovStack. You can find us there. We've been working hand in hand, for example, with MOSIP in the last 4 or 5 months to have smoother integration between DHIS2 and national ID systems. As the technologies come along that you're working with, it's very good for us to know which of them you need or would wish for closer integration between DHIS2 and these systems. There are many of them that are out there and approaching us regularly. Our team is not so big. We have to prioritize a bit how we focus our interoperability efforts. I'm not the interoperability lead, so there's not a lot of specific detail I can give you on that question, but I would request that as much as possible, communicate to us what you see as the most crucial parts of your technology infrastructure where you struggle to connect with DHIS2. Because our mandate, of course, is to make sure DHIS2 is very interoperable. It's an open system. Everything that we develop is meant to be something that can be fitting into your national framework. And so we'd love to have a better sense about which of the technologies are most important. You mentioned OpenFN. We actually are working very closely with OpenFN as well. Right now, the Digital Public Infrastructure Summit is happening in Cape Town. Some of my colleagues are there doing some shared panels with OpenFN, and we're working on being able to produce some more materials indicating how to use OpenFN with your DHIS2 as well. So you should be seeing more information from us in the coming months about some of these efforts. And we'd also, again, love to hear from you about where to focus.
Thank you, Mike. We've also received a few questions on just help for DHIS2 use in their countries, on documentation for different things. I have a few colleagues that have replied to you in the chat, but as you can see, on the slide here, we have included a few sort of additional resources. So when we send you the presentations, the slide deck, these links will be included later today. You can reach out to us if you have any additional questions or requirements or needs on how we can assist you with your DHIS2 implementations. Yes. I think we have a question here as well. The DHIS2 implementation strategy is entrenched country focus on the public HMIS. Don't you think that the long-term sustainability of the system lies in a realistic transition plan to move implementation into the private sector as well? National HMIS are currently underreporting as the private sector is not included. Mike?
Yeah, again, I have some thoughts. We don't specifically exclude the private sector. In fact, we've had a several years project running in Pakistan now to extend the TB system that was the national public sector system to all private providers of TB care. This is also something I just had a meeting in Kigali with the largest private pharmaceutical group to include their reporting. What is more difficult in the private sector, if we're talking about the data, is that it's very fragmented, much more so than even when we complain about a fragmented public sector information system. The private sector, there's so many different actors, and they don't usually have a mandate to report to the public sector system. And so from a data perspective, it does take some significant government-led effort to expect a level of kind of synchronized or aligned reporting coming out of the private sector. If you're thinking from the economic side of it, of getting money from the private sector in order to sustain digital public goods, that's a big part of why we also are opening up mechanisms like the shared service fee, because we know the private sector is using DHIS2 quite extensively. In fact, well outside of the health realm, there are many companies and private actors across the world that have found DHIS2 and have used it however they'd like. we want to open up more of a pathway to be able to obtain a revenue stream from those actors, which can in turn support the digital public good for everyone and particularly support this mission. So just to say, we don't think of the private sector as something that's out of our scope of emphasis, but rather that the main clients that we are building the software for is the public sector and LMICs. But there's quite a lot that can be done with and by the private sector.
Mm. Great. Thank you very much, Mike. I think that's all we have time for today. We're unfortunately running out of time. Thank you all so much for your questions and for attending this webinar today. And thank you to Global Fund for supporting this webinar. Thank you to our country representatives for their great presentations, and to my colleagues for also being here and presenting. As I said, the slides, including the links, together with the webinar recording, will be shared by email later today. Yeah, and without further ado, I think that's it. Thank you so much. Please reach out to us if you have any additional questions or anything we can help you with. Thank you.